Good afternoon or good morning, colleagues and friends here or online. Welcome to the 95th Global Health History Seminar. Today's subject is Chikungunya. The Global Health History Seminar series was established in late 2004 and co-hosted in Geneva and elsewhere by the World Health Organization and the WHO Gravid Center for Global Health Histories at the University of York. It is supported by the Wellcome Trust Seminars. It is supported by the Wellcome Trust Foundation. Seminars take place almost once every month and are broadcast via the internet. I'm honored to introduce my co-chair, Professor Sanjoy Bhattacharya, a bit far over there, Director of WHO Gravid Center at the University of York, and our two speakers today, Dr. Karine Aasgaard Jansen from Umeå University in Sweden, and Dr. Roman Velayudhan, Coordinator of Vector Ecology and Management from the Department of Control of Neglected Tropical Diseases at the World Health Organization. Each of the two presentations will last for about 25 minutes, followed by the questions and answer session for both speakers, which will be chaired by Professor Bhattacharya. Kindly remind everyone to speak into the microphone and give your name since the event is broadcast. Our first speaker is Dr. Karine Aasgaard Jansen. Karine holds a MSc in Social Anthropology and a PhD in Cultural Studies from the University of Bergen, Norway. She works primarily in the field of medical anthropology, and her thesis, which looked at the 2005 to 2007 Chikungunya epidemic in Réunion 2013, is based on a total of 8 months of ethnographic field work in Réunion in 2009 and 2010. She is currently a postdoctoral fellow at the Department of Culture and Media Studies at Umeå University, Sweden, in the larger research project Epidemics, Vaccination, and the Power of Narratives on the Swine Flu Pandemic in Scandinavia. As of next summer, she will continue her studies on the Chikungunya epidemic in the Western Indian Ocean, as she recently received research funding from the Swedish Research Council for a 3-year comparative ethnographic study on Chikungunya in Mayotte, Réunion, and the Mauritius. So, Karine, the floor is yours, please.
Thank you for the introduction, and thank you so much for the invitation to come here to the WHO headquarters to give this lecture on Chikungunya in the Global Health Histories Seminar Series. I'm both honored and delighted to be here. So, from March 2005 to April 2007, the Indian Ocean Island and French Overseas Department, or DOM, of Réunion experienced for the first time ever an epidemic of the vector-borne disease of Chikungunya. Chikungunya is a virus carried by the female Aedes albopictus and aegypti mosquito, and takes its name from the Makonde language on the border between Tanzania and Mozambique, where the first case of the virus was isolated from the blood of a febrile patient in 1953. Chikungunya can literally be translated to that which bends up, and refers to an infected person's characteristically arched back, resulting from symptoms of arthralgia, as the virus attacks the joints and leads to painful swellings and substantially reduced motor functions. These symptoms may last for a few days only, or in some cases for several years. Other symptoms include fever, headaches, and rash. And there is, as of now, no effective vaccine against the virus, but infection results in lifelong immunity. With 266,000 cases and 250 deaths, Chikungunya infected almost 30% of Réunion's total estimated population of 802,000 inhabitants during the epidemic on the island. But before I continue to go into the more specific details of the case of chikungunya in Réunion, I would like to take a brief moment to situate my studies by giving you a short introduction to medical anthropology, as I guess many of those of you are present here in Geneva today, and perhaps also some of those who are listening online may not be so familiar with the field and its effect on both choice of research questions and in turn research findings. So medical anthropology is often described as a subfield of social anthropology and is to a large part defined by its explicit interest in and focus on the cultural dimensions of health, disease and medicine around the world. The difficult concept of culture can here be understood in its widest terms, and to paraphrase the well-known anthropologist Clifford Geertz, as the webs of significance or meaning spun by people themselves. The prime focus of medical anthropological inquiries is on how disease and illness are experienced, explained, and treated at a local level. Furthermore, diseases are considered to be a social, cultural, and historical construction, in addition to a matter of biomedical concern. And a central argument following from this idea, and I will demonstrate here today as well, is that disease cannot merely be investigated as an isolated issue of health, but that it also forms part of local cultural knowledge productions and of global geopolitical concerns. So at the core of my study of the chikungunya epidemic in Réunion is thus a critical approach to how political discourses regarding disease and contagion may feed into and contribute toward the shaping of local illness narratives or local illness experiences. And in this lecture, which I have titled Negotiating Disease Etiology, I will argue that chikungunya, as a new disease to the island, was made sense of within already existing Réunionnais narrative frameworks of disease transmission and prevention. And these, in turn, were to a large degree influenced by public health discourses in which the post-colonial relationship between Réunion and France has figured prominently. Moreover, I will investigate how the vector's breeding grounds in so-called artificial containers of stagnant water, on the one hand, and previous and recent public health interventions against vector-borne diseases on the other, have contributed toward the stigmatization of chikungunya, its carrier and its sufferer. And I will also discuss in what ways this may have led to the rejection of chikungunya as a vector-borne disease among many Réunionnais. And this is despite widespread and easy access to public health information regarding its mode of transmission. And my argument is that this neither could nor should be understood as a question of so-called health literacy. And instead, the pursuing of alternative etiologies seemed to empower people as it enabled them to negotiate their options and choose among illness narratives. The chikungunya epidemic began with small outbreaks on Lamu Island in Kenya in June 2004. The disease then spread across the Western Indian Ocean to the islands of the Seychelles, the Comoros, and Madagascar, before it finally reached Réunion and Mauritius. Chikungunya had never previously been diagnosed in the region. The virus was first detected in Réunion in March 2005 and communicated to the general public by the Regional Department of Health and Social Affairs, or DRAS, in April 2005. And DRAS is the governmental agency responsible for carrying out vector control and eradication on the island. And according to the French Public Health Authority's estimates, the epidemic was assessed to be over by the end of July 2005. DRAS additionally assured the Réunionnais population that the epidemic was closely monitored and that, in any case, chikungunya was benign and thus non-fatal. None of these statements proved correct. Instead, the epidemic peaked in the first 2 months of 2006 with the registration of more than 25,000 new cases in the last week of January and an astounding 45,000 cases in the first week of February. Moreover, severe health complications were reported in several cases. And chikungunya also claimed its first victim when a 10-year-old boy died. The boy was the first documented casualty due to chikungunya worldwide. And at this stage, the French government acknowledged the potential gravity of infection and responded to the situation with economic, medical, and preventive assistance. In total, 91 million euros were contributed toward research, sanitary, and financial relief. The government also mobilized 720 locally stationed and metropolitan, that is mainland or European French military personnel, to conduct so-called demosquitifications, which is the local term for prophylactic measures such as the spraying of insecticides. These interventions only took place, however, a year after the virus had first been documented in Réunion, and almost 2 years since the epidemic first broke out on the new island. And both misinformation regarding the severity of the epidemic and the government's late and lacking intervention led to a massive local criticism of the French authorities' alleged neglect of their overseas citizens. It also gave rise to the general population's mistrust in the public health administration, trust included, and to the politicization of the epidemic with the French government on one side and the Réunionnais on the other. The findings that are discussed in this paper are based on a total of, as Sting mentioned as well, 8 months of ethnographic fieldwork in Réunion in 2009 and 2010. The methods that informed the study were qualitative and consisted of participant observation, writing of field notes, repeated visits and interviews with research participants, including 16 key lay informants, and public health and sanitation staff, entomologists, and epidemiologists. And in order to examine the multi-sidedness of the epidemic, that is, its personal, social, and political consequences in Réunion, I also analyzed various written sources on chikungunya, such as local and national newspapers, public health reports, and preventive public health campaign material. In addition, I looked into governmental and newspaper reports of the massive anti-malaria campaigns on the island during the 1960s at the departmental archives in Réunion's capital, Saint-Denis. And this was done in order to compare public health discourses on chikungunya with those of the previous vector-borne disease, its spread, and the preventive measures that were adopted. And the location of my fieldwork was, as you can see here as well, Saint-Pierre, which is a town on the west coast of the island. And Saint-Pierre has a population of approximately 26,000 and was also among the cities that were the most affected by the epidemic because of its hot and humid coastal climate, which provides favorable conditions for vector breeding. The third case of chikungunya was, for example, detected in a neighborhood, and that's the neighborhood, Quartier Lavoie, inhabited by several of my informants. And according to Rod and Setben, quote, the relationship between the socio-economic position and the risk of chikungunya disease is relatively well established, end quote. Poor sanitary conditions, which are more likely to be found in impoverished areas, may thus contribute toward the infection of vector-borne diseases, chikungunya included. And the risk of contracting chikungunya increases with exposure to the vector's breeding grounds in stagnant water, which is gathered in both natural and artificial reservoirs. Natural containers are, for instance, rain ponds and plant axles, while artificial ones include gutters, flower pots, bottles, plastic food containers, and discarded car tires in densely populated and domesticated environments. As such items are commonly found close to people's homes, Grass claims that 70% of mosquito breeding grounds are located here. Exposure to vectors is also enhanced by the Aedes' activeness during the day and local living patterns. Due to the warm temperatures, most Réunionnais spend large parts of their domestic lives outside. And this is also reflected in the traditional architectural layout of Réunionnais housing, or that is a case creole. And for example, in a Réunionnais garden, or a jardin creole, people plant flowers in pots instead of in the ground, and may at times have quite a considerable quantity of potted flowers. And then I'm talking about the 50s or even hundreds. And the sources that are used to collect excessive water function therefore as favored breeding grounds for the Aedes mosquito. Furthermore, unlike flower beds, such pots only require a small enclosed space which may well consist of tarmac instead of soil. And the jardin creol is therefore common in urban areas, including in impoverished neighborhoods such as social housing estates, consisting of terraced houses rather than blocks of flats. And as there is no known effective vaccine against the virus, medical and sanitary authorities consider eradication of mosquito breeding grounds to be the most efficient preventive measure against infection. Public health campaigns in Réunion have therefore been mostly directed towards private households. And RAS has, for example, carried out regular inspections of people's gardens since the onset of the epidemic. And they also continued to do so during my last fieldwork in Réunion in late 2010. And in order to observe such garden inspections and learn more about how they were received by the local population, I actually joined the DRAS team of field agents during an intense week of my fieldwork following the discovery of 3 cases of chikungunya in August 2009. Fortunately, as DRAS managed to isolate these cases early, they did not spread. However, the previously mentioned flower pots are not the only possible source of mosquito problems in a jardin creol. While potted flowers are normally only found in the cour devant, which is in the front garden, facing the street, the cour derrière, or the back garden, commonly houses the household's poultry, dog or bird cages, and various sheds. And by the way, please bear in mind that I refer to these terms in creole and not in French. So the cour derrière is private, that is, it's only meant for the household members and is often used to wash and dry clothes, clean rice and lentils in the outdoor kitchen, to store gardening tools or other useful objects, and sometimes various discarded items, as you can see here as well. As a general rule, guests are received on the varang, which is an overbuilt terrace in the front of a classe creole. However, both flower pots in the cour devant and the accumulation of items in the cour derrière may lead to a flourishing environment for mosquitoes. So during the epidemic in Réunion, demosquitifications were primarily conducted by mainland soldiers together with DRAS. And the soldiers' unawareness of local conceptualizations and practices concerning intimate and public spheres within a jardin creole led at times to frictions with residents, as many of the soldiers disregarded and so trespassed the cultural spatial boundaries of la cour devant and la cour derrière. And one of my key informants, 72-year-old Gabrielle, who had herself suffered from chikungunya, risked, for example, a substantial fine for denying them access into her cour on at least one occasion. She also declined their offer of free anti-repellents, in addition to refusing DRAS to conduct a demosquitification. And Gabrielle and other informants with her often compared these garden inspections with those taking place during the extensive governmental anti-malaria campaigns on the island during the 1950s. With the introduction of DDT in 1939, the fight against malaria accelerated worldwide. And in Réunion, this work was undertaken by the governmental prophylactic services, which was later replaced by DRAS. And these agents not only conducted garden inspections similar to those during the more recent chikungunya epidemic, but also sprayed both the insides and outside of people's houses with large amounts of pulverized DDT mixed with petrol. And this method was known locally as house painting and considered to be highly efficient, as it not only rid people of mosquitoes, but also of lice, bed bugs, fleas, scabies, and ticks. So despite the island's departmentalization and full inclusion within France in 1946, to be an overseas French department actually means that today the island's residents have French passports. They serve the euro, or the local currency is the euro. The island is a member of the European Union, and Réunion's prospects for inclusion within the Schengen area is actually currently under discussion. But despite all this, French welfare provision and social reforms were only put on the agenda in Réunion during the latter half of the 1960s. So the majority of the Réunionnais were consequently suffering from severe poverty and poor sanitary conditions at the time, which in turn contributed to the spreading of various vector-borne and parasitic diseases. And this past is intrinsically connected to French public health interventions on the island, particularly among elderly Réunionnais. And as a result, the biomedical etiology of chikungunya was often found to be stigmatizing, as it allegedly passed judgment on its sufferers' domestic hygiene. And 72-year-old Sylvain, who lived in a social housing estate, even compared mosquitoes to rats, the classic symbol of the bubonic plague. While Gabrielle insisted that she always kept her house and garden clean, there were also no mosquitoes there. On basis of her immaculate household, Gabrielle also informed me that it was highly unlikely that chikungunya transferred via mosquitoes. And to my surprise, this was even the case among several younger informants who had no experience themselves of the previous malaria eradication programs. And instead of considering chikungunya as a vector-borne disease, many rather claimed that the disease had spread through bad air, in a fashion similar to how contagion is explained by miasma theory. Although germ theory largely replaced miasma as an explanation of contagion from around the 1870s and onwards, my argument is that it can still be put to use by lay people in order to make cultural sense and meaning of disease. Miasma theory does, after all, imply so-called exposure to unsanitary environments, in particular noxious mists or vapors from decomposing organic matter close to people's homes, which can be compared to mosquito breeding grounds in dirty and stagnant water. Among my 16 key lay informants, 7 leaned mainly upon biomedical explanations, mosquitoes being the cause of chikungunya, while 9 claimed that chikungunya transmitted through air. However, there was also an overlap between the various explanations, as some informants expressed considerable insecurity and ambivalence regarding the etiology of chikungunya. My claim, however, is that despite the close connections between miasma theory, colonial medicine, and early hygienic approaches to public health in tropical locations, miasma paradoxically appears to be less of a stigmatizing disease etiology in Réunion than vector-borne. And this is, as already argued, partly based on previous experiences with public health interventions, but also by the discourses surrounding them, in which the wider post-colonial relationship between Réunion and France has played a central part. In 1959, the Réunionnais Communist Party declared the island's right to independence from France as a result of, among other things, France's apparent unwillingness to deal with the island's extremely poor economic and sanitary conditions. However, in face of colonial emancipation in other parts of the Indian Ocean, Réunion had become a key military location in the region. French and local opponents of the idea of emancipation therefore ensured that Réunion remained French by withholding welfare provision until the island's residents voted against independence in the upcoming election over autonomy in 1963. They argued, for example, that independence would lead the island into even more pressing social conditions, while continued departmentalization would be rewarded with substantial economic, social, and health reforms. And furthermore, by combining anti-independence and anti-communist propaganda with public health rhetoric, Réunion was strategically juxtaposed against what was described as the underdeveloped, disease-ridden, recently independent countries nearby. And it was, for example, claimed that if Réunion was departmentalized, it would become African, like the recently independent Mauritius and Madagascar, and as a consequence, suffer similar hardships. France, in contrast, could offer Réunion and its residents inclusion within the so-called enlightened, civilized, and democratic world of European France. So if the Réunionnais were disloyal to France, that is, claimed autonomy, the rhetoric was that they would also continue to suffer and to go hungry. This strategy, which has been described as welfare colonialism, not only ensured that Réunion remained French politically, but also made Réunion French on both a discursive and a practical level by symbolically lifting the island out of its Indian Ocean context. During the latter half of the 1960s, substantial infrastructural changes were, for example, initiated with regard to housing, schools, roads, and electricity. Moreover, after 20 years of local political struggles to obtain equal rights with other French citizens, welfare was finally provided through health insurance, social and family allocations, and social housing laws. My argument is that such post-colonial discourses and practices have had a lasting impact on, among other things, local understandings of disease transmission, particularly caused by so-called tropical disease in Réunion. Tropicalism, meaning the association between disease and so-called exotic and primitive places and people, are, for example, still reflected in many Réunionnais illness narratives. And this is also reinforced by science communication. In the dust jacket of the popular scientific book, Le Chic, Le Choc, Le Chèque, which is the Chikungunya, the shock and the Chèque, from 2006 by two locally based medical doctors, Chikungunya is, for example, introduced to its readership as follows. Réunion has painfully reconnected due to the interference of Chikungunya with its ancestral tropical and African roots. What is this mysterious virus with a cannibal name, which bends the spine and eats at the cartilage and pride? Despite the lasting threat of subtropical and vector-borne diseases in all the DOMs throughout the Indian Ocean and the Caribbean, Chikungunya and dengue were also only included in the French notifiable disease surveillance system as late as 2006, and that was actually after the Chikungunya epidemic. And many Réunionnais thus relate tropical disease, Chikungunya included, to the island's colonial past and not to its French present. However, although local responses to the epidemic may be understood as a challenge of past and current public health interventions, by employing miasma as theories as an alternative disease etiology, they also mirror colonial racialist health discourses. Nevertheless, the main point I want you to take home from this case is how disease is interwoven in culturally complex webs of meaning-making. For example, miasma may no longer be an accurate or valuable biomedical explanation to disease transmission, but it is nevertheless commonly used to explain contagion metaphorically, as it may provide people with the conceptual tools to reason about disease. And as illustrated by the Chikungunya epidemic in Réunion, disease is much more than a medical diagnosis. Thank you.
So our second speaker is Dr. Roman Velayudhan. Dr. Roman Velayudhan, MSc, PhD, is at present coordinator at Vector Ecology and Management Unit, Department of Control of Neglected Tropical Diseases of WHO, Geneva. He is the focal point for dengue, chikungunya control, integrated vector management at WHO HQ. In his present assignment, he also supports the WHO pesticide evaluation scheme and the Vector Control Advisory Group. He joined WHO in 1989 and has worked in Solomon Islands, Fiji, and the Philippines. His field of expertise includes malaria control and neglected tropical diseases. Prior to joining WHO, he worked for the Government of India at the Vector Control Research Center, Pondicherry, WHO Covering Center for Vector Biology and Control. So Roman, please.
Thank you very much for the introduction, and I also would like to thank the organizers for giving me this opportunity. I have attended several of the global health history seminars, but never thought I would get an opportunity to make a presentation. So I really consider it an honor. So my topic is basically on vector control of chikungunya vectors, and as you have heard, the disease does not have medicines nor vaccines, and all that we have is to control the mosquitoes. What we need to remember in this process is that in the 60s, due to the fear of yellow fever, the whole of Latin America was successful in eliminating the Aedes aegypti. And this was basically through the efforts of William Corgas and Fred Soper, with an extremely well structured program which was sustained in which was operated almost like a very precise operation. But the challenge is, of course, it is very difficult to sustain it, and things later slackened. So till as you can see in this graph, till 1971, we really didn't have much of Aedes aegypti, but thereafter in South America, the vector had really reconquered most of these areas, and now it is even spread right through. So it is possible to control. There's no doubt about that. And the challenges are many. First of all, of course, vector control lacks resources, and very often it is treated as an outbreak disease, and the equipments, chemicals, they arrive late, and most of these delayed response is really ineffective, because by the time many of these epidemics would have reached the peak. The decentralization of health service is also a challenge, because you need to train staff at various levels, and you have to ensure that proper insecticides are used, especially those insecticides which are recommended for public health. The other challenge which chikungunya and dengue have in common is we still have to grapple with urban health delivery system. How do we address urban health? How is this, who will be responsible? And of course we say that this goes beyond the mandate of ministries of health. But again, the issue of delivery, responsibility, and community involvement in an urban setting is one of the biggest challenges. And at the end of the day, vector control gets blamed for being ineffective. Now, the other challenges we face is, of course, we have challenges of increasing burden of the disease. There is also deficiency in understanding the virus transmission, methods to assess the risk and failures of effective surveillance and control. And also there are issues like entomological measures of risks are still weak. Epidemiological impact of vector control is again weak, because hardly there are any studies on that. There's growing resistance problem of insecticides, and of course this disease is a spatial scale in transmission, and it is temporal, it's dynamic. And there is, of course, the challenge of research design in vector control, which I'll address in the next few slides. The other challenge is, of course, chikungunya in particular migrates, which is both urban, semi-urban, and it is also affects rural areas. So there is a movement, and we must remember that the virus is actually carried by the humans, not by the mosquitoes. The mosquito, we will come to that in a later slide. So it's a human movement which is critical, and we have to understand this more carefully in addressing the transmission. The human movement also helps us to identify the hotspots, and prompt response can be taken. And we have in grey literature successful chikungunya control in New Caledonia and Singapore, when the hotspot was detected early and prompt response was taken. Surveillance, intervention, and prevention can easily be initiated once this is done. And of course, we today have to address vector control in terms of IHR, where we have monitoring vectors at points of entry. The other issue is growing resistance. Resistance is a global problem which touches not only malaria, but dengue, chikungunya, and all vector-borne diseases, because the vectors have become resistant to most of our insecticides. And our insecticides, when we talk about insecticide groups, we do not have a new insecticide since 1989 or 1988 to be precise. There is no new molecule, and we have been harboring on the same class of pyrethroid insecticides. And today, pyrethroid resistance is widespread, as you can see on this map, and it is growing day by the day. And the challenge is even more when you think that the vectors of malaria, sandflies for leishmaniasis, they are also developing resistance. And if the programs don't talk to each other, then we are compounding the problem, because in an area where the vectors overlap, if malaria is spraying pyrethroid and the dengue vector is already there with resistance, you are worsening the situation, and vice versa. So there is a dire need for a programmatic coordination in managing resistance. The other issue is organophosphate resistance. This is the other compound which we use in drinking water, Temephos. is very widely used, but again studies have shown that the effectiveness is compromised. There are several genes which are responsible for this metabolic resistance, and we need to minimize the selection of resistant phenotypic genes if we have to control the problem of resistance. So insecticide resistance is one of the biggest challenges faced in vector control today. The other factor today is climate change. Of course, malaria has got much better evidences today, but having said that, there is both chikungunya and dengue. There is evidence that erratic water supply, for example, aggravates the problem because you hoard water at home, and this naturally leads to vector breeding. There is also increased temperature, be it 1 degree or 2 degree. It favors the multiplication of the vector as well as the parasite or the virus in this case. So the rainfall, relative humidity, El Nino have all been correlated now for the new transmission, and in fact there are more studies currently being in progress. WHO has also produced an atlas on health and climate, which includes a chapter on both malaria and dengue in it, and it highlights some of the interactions between the climatic factors and these vectors. Now, who are these vectors, especially for chikungunya? This is an interesting issue. When you talk about malaria, we are talking about a disease which is transmitted by nearly 66 vectors globally. So there's 66 species of anophelines or even more which transmits malaria. But here are 2 species of Aedes, Aedes aegypti and albopictus, transmitting multiple diseases. You have yellow fever, dengue, chikungunya, Zika. So you have just 2 opponents, but 4 diseases. So I always say in a lighter vein that these are the most beautiful mosquitoes you can see. They are very colorful, easy to recognize, and they with very good black spots on their legs. The characteristics basically between the two is Aedes aegypti is more tropical, subtropical. It lives mostly in urban areas. It has a habit of multiple feeding, so it is not satisfied by feeding on one person, and that is one of the reasons why dengue and chikungunya you get clusters within the same family, because this same mosquito would bite several people and transmit the virus. So there is a clustering in a particular locality of these diseases, mainly because of this multiple blood meal by Aedes. It prefers human blood. There's no doubt about that. It lives in and around houses, preferably breeds in artificial containers. The eggs of both these species can withstand desiccation, and this is something which is very often overlooked, which means that if a dry pot is kept without water but there are eggs in it, the next time you fill it, the eggs will hatch. So in a laboratory it is so easy to rear them because you can dry up the eggs and keep it for 6 months, later just put it back in water and off it goes. It hatches within 24 hours. So this is a fact of this mosquito, and this is one of the greatest adaptability which we find extremely challenging when we deal with it. The flight range, this is what I really wanted to say. Both of them are 400 to 500 meters. They are very weak flyers. So really they do not transmit much. They are in and around your house, and they don't fly very far unless there is a strong wind. And the virus is usually taken from place to place by humans. In terms of susceptibility, Aedes aegypti is moderately susceptible to chikungunya, but Aedes albopictus is more highly susceptible to chikungunya. Now, if you talk about albopictus, it is both tropical and temperate. In Europe, it hibernates. Aedes albopictus has been found in over 22 European countries, and it is both urban and rural. It likes to feed on one person, so that way we are better off. It is an opportunistic feeder. It even feeds on animals. It lives both inside and outside houses, prefers tree holes, axils of leaves, and so on. So this is just to give you some example. You have seen some slides earlier. The axils of leaf of a banana or one of these plants just holds water. Even up to 100 ml is enough, and that breeds mosquitoes. Some more breeding sites. And these are ideal. The used tire is one of the biggest culprit in the transmission of dried eggs, because these tires are favored by mosquitoes. Mosquitoes like black color. So if you wear a black socks, you are attracting mosquitoes, honestly. So the black color of a tire brings them there. They lay their eggs inside the tire. The eggs can remain dry and hatch when it comes in contact with water. So tire is one of the biggest breeding sites for Aedes mosquitoes. And this just shows you, especially for albopictus, how this Asiatic mosquito, which was known as Asian tiger mosquito, the blue area shows those areas where it was prevalent till 1980. And now the red area is after 1980, and it is growing. It is much rapid. Actually, the map is incomplete. We still have to spot more places. And as I said, in Europe alone, it has spread in 21 countries. We have several compounds for larval control of mosquitoes, and some of these WHO recommended compounds include organophosphates like Temephos, pyrimidine methyl. We have insect growth regulators. We even have a biopesticide, which is Bacillus thuringiensis. And these are quite effective in controlling Aedes at the larval stage. Then, of course, the most popular one, which you saw in the previous speaker, was the fogging. Is fogging really effective? It's a very common question. Honestly, when it is done, ultra low volume fogging over a 6-week period, as you can see, it is quite effective. But the thing is, after 6, if you slacken it, the population bounces back. The mosquito population bounces back. So this is a labor-intensive, costly operation, but it's a question of how well can you sustain it and how long can you do it in an area. But it is possible to suppress the population. But at the end of the day, we really need to look at combining methods, just not depending on one method of control. There are these container covers, which actually in places like Philippines, I have seen communities going to the shop, paying 60 pesos and buying them because they value the cover, not only for the mosquito, but also to cover their water from dirt. And this is quite effective. If you can promote this more aggressively in all breeding water storing containers, then we really can suppress mosquito breeding. This slide really summarizes the range of vector control methods we have today for Aedes control. First of all, we have a lot of compounds like what I have shown you, which controls the larval breeding, and these can be insect growth regulators, and they can also be polystyrene beads and so on. But there are fishes and biological copypods which can also eat up the larvae. But what you see on the right-hand side are the new tools coming through. There is a RIDL technology, which is a genetically modified mosquitoes. There are toxic sugar baits coming through the system, Wolbachia-induced mosquitoes, curtains, and of course lethal Ovitraps. I will touch on some of these new tools coming through. So in WHO, we have established since 2013 what we call Vector Control Advisory Group, which is a joint collaboration with the Global Malaria Program to look at new tools. And one of the new tools which was submitted to us and which is now in its final stages of phase 3 evaluation is this RIDL technology, where a dominant lethal gene can suppress the population. And this is a male lethal gene, which the male mosquito goes and mates with the female. All the offsprings are non-viable, they die. And so in a matter of 8 weeks, the population can be completely suppressed. This has been proven in Cayman Islands and parts of Malaysia. But our biggest challenge is, from an entomological point of view, the method is very successful, but they need to prove the epidemiological impact, whether this can really have an impact on the transmission of chikungunya or dengue. So this is now being field tested on Aedes aegypti, and there are trials going on in Brazil and few other countries. The next one is Wolbachia. Wolbachia is nothing but a symbiotic bacteria present in almost 60% of insects. It is naturally occurring in Aedes albopictus, but in Aedes aegypti, this was induced by a research group in Monash University in Australia. And Wolbachia now is self-propagating, and this symbiotic bacteria, once you inoculate it into the egg, thereafter the colony can be established, and such established colonies can then take over the wild population, and in a course of 8 to 9 weeks, you can get the threshold of nearly 80% of the wild population having Wolbachia in it. The advantage of Wolbachia is this bacteria shortens the life of the mosquito, one, and number two, it also prevents the multiplication of the virus within the mosquito. So the mosquito really doesn't pass the virus to humans. There are areas in Australia where this mosquito is quite well established now, and they are in the third year of follow-up. They are currently doing large-scale trials in Vietnam and Yogyakarta to really come up with the epidemiological endpoints. The third one is, of course, there are so many traps. Many groups have developed traps for mosquitoes. Traps have got dual purpose. They can be for surveillance, they can be for control. But these traps, if you place about 3 traps per house, it gives 88% control of Aedes population. Now again, this is also, many of these developers have now joined hands, and they are trying to do a phase 3 trial to prove that these traps are effective in controlling the transmission of chikungunya and dengue. The other one is, of course, the biggest challenge we today have is the lack of a randomized control trial for dengue. We have had that for malaria very successfully, basically for bed nets and so on. But here, for dengue control, randomized control trials, which are quite expensive, there is very few studies. But of late, these things have picked up. There is Wolbachia study going on. There is also a randomized control trial on spatial repellents in progress, and we hope that some of these trials will give very positive results very soon. One of those which has come up recently and published is the first trial result was a community-based approach of dengue control, and this was done in Nicaragua and Mexico, and this clearly shows that when you empower the community with sustainable control measures, non-insecticidal based, it leads to decline in dengue, both in the population as well as serology evidence in children. So this is in fact recently published in the British Medical Journal, and it is the first trial of a randomized control nature with epidemiological endpoint. And this is of course an expensive study, but similar studies are needed basically to really enforce the vector control tools for dengue and chikungunya. So essentially, what are we aiming at? At the end of the day, most of these problems can be addressed if we have an integrated surveillance. When I talk of integrated surveillance, we need vector surveillance to work hand in hand with lab as well as cases from the clinics. And if this can be coordinated, there are a few countries who are already doing that. We would be in a position to select appropriate vector control tools and carry out immediate control operations. So basically selecting the tools which basically should address both the immature stage and the adult. We need the resources, you implement and monitor it. So the answer is to develop tools basically both for chikungunya and dengue is sustained vector control. We need surveillance, a strong surveillance with utilization of data, identification of the hotspots or area of transmission, adequate resources and personnel, and of course integrated vector management with combination of methods targeting both the larval as well as the adult population. We need at least 2 methods, and if possible, for example in Laos when they did a social focal group discussion with communities and explained how this mosquito breed, the community said the best to control is to clean and scrub all water containers once a week. It's a very nice message. If you can do that, clean and scrub all your water storage containers once a week, most of these mosquitoes won't survive, because you will destroy the eggs. The larvae anyway need 7 days, and by the time if you consume the water, they cannot breed. So it is possible with integrated vector control and sound management. We really need to able to control chikungunya and dengue. So in conclusion, basically current tools and strategies have not been fully evaluated for both chikungunya and dengue, because we always respond for epidemic, and epidemic response is very weak on monitoring and evaluation. This is true beyond doubt. There is hardly any dengue or chikungunya publication which can be accepted for Cochrane review because it is weak on the monitoring and evaluation. This current research of new tools and delivery mechanisms still needs to be addressed. The biggest gap of current vector control is how much coverage is needed, especially for chikungunya and dengue. There is no large-scale trials in progress. So this is like malaria, for example, there is 500 million nets out there. It's a huge operation. And naturally, it has an impact. When you have more than 80% coverage in a community, it gives a community impact. The whole community is protected. We don't have that sort of large-scale operations. General consensus is that, of course, one approach will not solve the problem. We need combination of methods. Now, there are vaccines coming for dengue. Chikungunya, at least, there are 2 candidate vaccines, one in phase 2 trial and another one in phase 1. The outlook is really we need to combine the tools we have for prevention, vector control and vaccine, and we need to see how this works. As I said in the beginning, urban health and health delivery in an urban situation is still the challenge which we need to address in a more comprehensive way if these vector-borne diseases have to be addressed. And of course, sustainable vector control needs to be promoted. Thank you very much. I also need to thank Professor Tom Scott because some of his slides I've used with his permission. Thank you.
Two fantastic papers. Thank you. I'm Sanjay Bhattacharya. I'm from the Center for Global Health Histories, which is also the WHO Collaborating Center for Global Health Histories. If I could remind all of you, any comments or questions, could you please identify yourself for our colleagues online. So if I could just start off with a question for Karine. You showed some very powerful images of fumigation and officials with masks and protective suits. So people who were fumigating people's houses, were the people whose houses were being fumigated given the same level of protection?
Absolutely not. They were not given that type of protection at all.
So,
is this on?
Yes.
Yeah.
So does that then become a basis for resistance?
Yes, it did. I don't have very much else to say, but that was also one of the problems, obviously. The fact that you would have mainland, as in French soldiers, coming into Réunion Island 2 years after the epidemic had first been discovered in Lamu, and then a year after the first cases had been communicated to the general public in Réunion as well, which is a very late and lacking intervention. And then when they did come, they were mainly soldiers wearing full protection and fumigating, trespassing and fumigating people's houses. Yes, it definitely led to issues of resistance, which again contributed, I would say, to the development of alternative etiologies of how the disease actually spread.
Thank you. Questions, comments? Sir?
So David Ross from WHO Maternal Newborn Child and Adolescent Health Department. My question is mainly for both speakers, but from the lessons that you learned, Karine, what would you do differently from the next time that there's an epidemic, and similarly, for Raman?
Should I go first?
In terms of control, yeah.
That's a very good question. It's a very big question as well, and it's quite difficult for me as an anthropologist to answer. But I do believe that the most important part is actually to better the communication with the local population. And I do know that TRAS, for instance, is very well aware of how these problems arise, and they do know that they lack credibility among the Reunionese population in general. And I believe that actually talking to people, and when it comes to vector control, because for instance the fact that with these Reunionese gardens, they're lovely, but you have 100 potted flowers, which means that you will not be able to take out the sources and throw away the water on a regular basis. People just won't do it, and that does lead to problems. But they are, I think, just what they're doing now as well, and doing these garden inspections, is that there are actually local people who speak Creole as well. So they do visit people's houses, they do inform them about how to safeguard themselves against these vectors. And I think that is definitely the way to go. I think you need to start on a culture-sensitive, bottom-up approach and working with the local communities.
Well, just to supplement, what I would really do is essentially we need to properly monitor fever cases in an area which is vulnerable to these diseases. Any abnormal rise in fever cases needs to be investigated, and if possible, the hotspots can then be located and proper vector control initiated immediately. One of our challenges we face is, of course, we do not have good diagnostics. A diagnostic which can really prove that it is chikungunya or dengue in less than half an hour, we don't have that. Of course, there are rapid tests coming through. Some of them are reliable, some are not. But we need that tool to first do that, monitor fever cases. Then, of course, there is no harm in initiating a vector control within a radius of 400 meters. Though the mosquito breeds in pots and so many places, the priority has to be given to the most productive containers. What I mean is the number of larvae coming out. A used tire can generate about 500 larvae per day, and while a potted plant may have only 10. So essentially the challenge is identify the most productive containers, maybe the water stored drums or a tire, target them because they account for 80% of the mosquito population, and control those. And there are grey literature, essentially reports, both in New Caledonia, Singapore, Cuba, and few other countries where they have really suppressed chikungunya very effectively. In New Caledonia, with 25 cases, they were able to completely control it by this method of prompt action.
Okay, I have a question for Raman, please. So the massive outbreak in Kerala, did that put into motion any protocols that were then useful for later outbreaks? I mean, I'm talking about very recent history being useful in a policy sense, because there were about 3 million cases.
I think in that state alone, yes, they have put protocols, and they have actually strengthened entomological surveillance there. There are more entomologists now, both in Kerala and in Tamil Nadu, at district level, working and doing monitoring. So there is a certain level of awareness and monitoring going on. But the challenge, of course, in these places, especially Kerala being a tropical area, was that it was breeding more in the rural areas, especially with rubber tapping containers. So that was a challenge. It was a challenge which they didn't anticipate. But now they have made everyone aware. So they tilt the shell if the rubber is not tapped, and also in the rainy season. So some preventive measures are being taken now.
Stefan Hoyer, Global Malaria Program. Have there ever been any hemorrhagic forms and or any imported cases of chikungunya in Europe?
Chikungunya, but of course, the data shows we have had imported chikungunya in almost 10 countries. But there has been local transmission in 2009 in Croatia, or 2010 in France. And I think again a couple of times in 2012 and even recently in France there were outbreaks of chikungunya. So it was local transmission going on. There is no hemorrhagic form, but the challenge with chikungunya is that, and which is worrying, is that there is a long-term impact that many people end up with arthritis, and especially it is quite often age-linked. The older you are, you become more arthritic and you need prolonged treatment. So this is the problem faced by many chikungunya patients today.
I'm Jing Wang from the Knowledge and Ethics Research Department at WHO. I have a question to both Karine and Roman. Based on your rich field experience, in terms of the dengue and the chikungunya preventive interventions and control, what are the roles and the functions of the local community, and what are the challenges you have ever received? I think in your presentations it was mentioned a bit, but could you please elaborate? Thank you.
The role of the local communities. It's also a difficult question to answer because as an anthropologist, I mean, I do participant observation. I spend very much time in the field working with lay people, and I focus primarily on their experiences with the disease and their conceptualizations of them. So this isn't really on a policy level. And when I did my fieldwork, the epidemic was from 2005 to 2007, and I did my fieldwork in 2009 to 2010. So basically what I focused on is the politicization of the epidemic, and the fact that it was at that time, I mean, you have to consider preventive strategies in the future, but then the positive thing with chikungunya is that it actually does develop immunity. So when almost 30% of the population already had it, they actually won't have it again. So I think actually my only answer would be along those same lines. I mean, it is about raising awareness together with the local sanitary agents about how to avoid the mosquitoes in the vicinity of your own house, and that is ultimately something that people will be able to do themselves. But the problem is, of course, that they still think about everything that took place during the 2005 to 2007 epidemic. So there is so much resistance locally against adopting these measures. But they are still working on it, and I do believe that, you know, it is possible to make a difference. Yes.
I think just to supplement on that, basically, as I said, that publication from Nicaragua and Mexico clearly shows that if the communities are empowered and taught what is really needed for prevention, they make their own methods. There's no standard method, but they know how to do it, and they adapt it to their requirements. And that trial, which went for nearly 3 years, really shows it is sustainable, preventive measures and transmission can be controlled. So community empowerment is undoubtedly the most important component. But as I told you earlier, that in both dengue, chikungunya, the challenge is in urban health, how do you address the community? In malaria, it is easy. It is more easier in a sense that you go to rural villages, you talk to the communities, you ask them that here is a mosquito net, you have to use it. There is a lot of cooperation at a rural level. But in an urban center, very often in a locality, they are very transient population. You cannot capture them. Very often some people stay for 6 months and they disappear. In places like Manila, you won't see the same resident again the following year. So this is one challenge. How do we address that sort of issue? So the only problem here is we need to come up with sustainable measures. Something like treated curtains, used traps, which cannot be removed but which can be sustained in the community, and then probably some of these new tools will chip in. So community empowerment is essential, but we also need to go hand in hand with sustainability.
We have a question from Brazil, from Human Moman. Does the current epidemic of dengue, chikungunya and Zika virus in Brazil, all transmitted by the same mosquito, indicate that current vector control strategies are not sufficient and a new approach required? Roman?
Actually, the challenge in Brazil is multifold, in a sense that they are also faced with high levels of insecticide resistance, and these resistance vary in parts of Brazil. So the government is challenged with a situation where they are not sure which methods would work where, because you have to first monitor the resistance patterns and then deploy appropriate methods in place. But having said that, they have the capability and machinery to do it, and it's a question of the access and identifying the breeding sites and so on. But again, weather patterns also play a role, so the transmission dynamics is a bit hard to predict. But last year, in fact, Brazil had a very successful year in reducing dengue. They reduced it almost by 80%. But this year things are not going as per planned, but I hope it would improve.
I'm Olivier Talpin, doing anthropological work on traditional medicine in India. I wonder to what extent the treatment of the disease itself may be part of the solution to control its spreading. And I am also wondering if you are aware of some treatment from traditional medicine. I've had a report of an Ayurvedic practitioner, a physician in Kerala, who told me he could very well control the disease, and he even got the disease himself. And usually within 3 weeks he could control the disease with his patients. And so,
excellent question, but honestly, my answer is not going to be straightforward, because there are several claims. I agree. There are several claims, and in pockets it is proven that communities do accept it, and it seems to be successful. But again, the question is, we need quite good studies on this, and this is where the traditional medicine is weak, because they are not able to fund large-scale trials and studies. The other thing is, which we were discussing earlier, of course, was in chikungunya, when the patients have acute arthritis. Ayurvedic medicines, mainly the massage and oil massage, has proven to be effective, and there are many patients who have benefited from it. But again, we need publications, we need hard evidence with trials to substantiate these claims.
So that leads me to my next question. Do you have any idea how to better the funding for traditional medicine?
That's the toughest question of all, because we don't have funding even for our programs. So if I talk about that, so honestly, I really don't have an answer, unless I think the best option would be, with the economic improvement in India, the local government and the local institutions, because there are traditional medicine colleges now, Ayurvedic colleges, they must take the initiative to do such large-scale trial, and I hope the local government would fund such studies.
Well, since there are no more questions or comments, I'd like to thank all of you for joining us today, and especially the speakers for joining us and presenting such effective presentations. Thank you. I'd like to put on record our thanks to the Wellcome Trust, which has consistently funded all these GHH seminars, and WHO colleagues, without whose help none of this would ever take place. But most of all, thank you all for joining us and making time at what must be a busy time before Christmas. So happy New Year to all of you.